You bet. I'll take it from here. Yeah, so I'm a MD. I'm a psychiatrist and an addiction psychiatrist. I did my training here at UCLA. I'm in, I say here because I'm speaking from Los Angeles, where it's the morning still. And I guess it's a little easier to smile when it's bright and sunny outside with clear skies and all. But yeah, so I did my training here at UCLA in psychiatry, and then I went up to the University of Washington for addiction psychiatry. And in the course of doing training, I got really interested in ketamine, and eventually wrote a review paper and had that published, and that led to me starting this practice basically right out of training. I moved back to Los Angeles in late 2015 and opened this practice. And so this retrospective chart review covers the period of time from basically when I started doing ketamine in early 2016 through when we decided to cut off data collection for the analysis portion of the paper. And that was late 2022. So it's about 6 years of data points. And let me pull up, I'm going to share my screen. But see, I've been in practice about 10 years here. All right. So here's the paper. Basically, we got 70 patients from a medical record system. I went through and counted them up. 70 people received at least one dose of ketamine, and that included about 1,100 sessions. So quite a few over 6 years. My plan here is to kind of go through the paper, maybe give an overview, and then we can spend a lot of time talking about it, and I can answer any questions that come up about the clinical procedures or whatnot, and we can have a discussion. But so yeah, this is a chart I was looking for. So 70 people received at least one dose of ketamine intramuscularly. There were a few folks who got compounded ketamine sublingually as a way to facilitate psychotherapy, but they weren't included just because of the disparate administration and different outcomes probably. So we split up this cohort of 70 individuals into two groups. One group was analyzed for efficacy, and that ended up being 55 people of the 70. And the reason why we only did 55 of the 70 is because not everybody received a full induction, meaning approximately 6 sessions. So what I have done clinically for years is recommend 2 sessions per week for about 3 weeks. The details are in the methods, but essentially 6 sessions over a month. Some people did 4, some people did 8. Those were considered completers. They were included, but there were some people who dropped out after, say, 1 or 2 or 3 sessions. If their treatment plan included doing an induction, they were included in this efficacy analysis. So people who dropped out after 1 session were still included. However, if people were accepted for ketamine treatment from an outside clinic for ongoing maintenance treatment, they were not included. So that's why this 11 here shows that they weren't included in this efficacy analysis. And furthermore, we decided to look at it response through the CGI criteria. So there were 4 people of the 70 who were already well enough, who didn't have sufficient morbidity according to the CGI, that they were essentially not that depressed, not that ill with substance use or whatnot. So they weren't included either, because it wouldn't be a meaningful analysis to say if they got better or not. So what did we find? Well, here's the table 1. The N equals 70 here in this column is everybody that we analyzed for side effects, for use of PRNs, and the efficacy is what I was describing here, this cohort. One of the interesting things that I'd like to highlight here is just the amount of suicidality in this cohort. So you can see over here, oh, it's not working too well. This area, you can see about 70% of the cohort, 70 to 80%, depending on which one you're looking at, have some level of depression or have some level of suicidality, pardon me. And it's actually quite a bit of active suicidality as defined by the CSSRS, uh, which you don't see too much in clinical trials because most clinical trials are excluding individuals like this. They're prospective. So this is one of the strong points of this study is it's a retrospective, it's naturalistic. It's people who have a lot of pathology, who are not doing well. And maybe that's going to affect the outcomes that we see here versus other papers too, or other studies. So a lot of diagnoses as well, a lot of different medications. People had tried, psychedelics. Some people had tried ketamine. Some people had tried MDMA in the past. The other notable thing in this cohort is quite a few people had substance use disorders. Quite a few people had some level of current substance use. That doesn't indicate a substance use disorder per se, but about 50% of the cohort had a substance use disorder per the DSM-5 criteria. Now, I'm an addiction psychiatrist, so I was making those judgment calls as to who has depression, who has a substance use disorder, who's in a, to be succinct or to be concise with it, who's out of control to some level with their use of substances. And we can dive into that here in a little bit. Yeah, here we go, the baseline characteristics. So you see anxiety disorders, about 80% of the cohort. Let me do it for the efficacy here. Substance use disorders, 51%. You can see it's quite a bit of cannabis and alcohol, occasional opioids as well. And pretty much everybody had depression. There's one individual who basically just who didn't meet the diagnostic criteria, but everybody else did. Now, the really interesting part is, let's scroll back up. I can show you the results. So we started with a pretty high symptom severity, CGIS, about 4.5, about 70% of the people with suicidality. And after these 6 or so sessions, plus or minus, some had 4, some had 8. This is over, about 3 weeks here. Seems like the dose started at about 0.5 milligrams per kilogram, ramped up each time. So by the end of those 6 sessions, it was about 0.9. And we saw that 84% completed the induction, 82% had a response. That's pretty good. And then 71% continued with maintenance treatment, meaning some level of ongoing ketamine-assisted psychotherapy sessions in perpetuity. Well, the plan was, let's do it in perpetuity or as long as you need it. And we'll get into that in a little bit about how long people engage for. So the doses of this induction, they were a little bit lower than maintenance because there's the clinical procedure was to essentially offer to go up with the dose gradually each time at each subsequent session. So it went up from 0.5 milligram to about 0.9 milligrams per kilogram. And during the maintenance sessions, there was about 1.1. And the maintenance sessions occurred about every 3 weeks, with surprisingly the response rates maintaining above 80% after 3 months, after 6 months. And I'll scroll down to the table and show you that some of those response rates did degrade over time. And the data there gets a little harder to interpret because there are so much attrition once you reach the 1-year mark and onwards. But Boris was so kind as to use his statistical prowess to give us some data here about the CGI-S, and there was significant improvements that were maintained through a year. And I believe it was the 3-year mark or 2-year mark where it stopped becoming significant, the CGIS from baseline to that time point. So side effects, what did we notice? Pretty much everybody had some dissociation. Pretty much everybody had some acute mood improvement. That's not really surprising. That's what we kind of expect from ketamine. Sedation was pretty common, 31%. Dizziness was pretty common. People feeling unsteady. Surprisingly, nausea was not that common. It was under 10%. This is, I believe, we're looking at the figures from this is over all the sessions rather than patients. So this is the session level outcomes. And anxiety, not that common. And notably, I would say in this study, I believe it was only one occasion I ended up administering lorazepam to individuals. So most of the time, the anxiety was treated by reassurance, just by talking, by occasionally holding someone's hand when they felt like they needed it. And that pretty much quickly resolved in most cases. Headache, not too common. One thing I was wondering about, how often are people having emesis? It really not that common. There were maybe 3 or 4 patients that were particularly prone to this, and that was something that could be relatively managed with a combination of Zofran and sometimes promethazine or scopolamine patch ahead of time. In higher doses, there were some individuals who had some amnesia, insomnia occasionally came up, and once in a while we had worse mood. People occasionally did get disinhibited and kind of almost confused and had some psychomotor agitation with sometimes yelling, sometimes rolling around on the floor, but that was pretty uncommon. It was maybe like one or 2 occasions here. And where are the PRNs? I want to show you that. Yes, here's what I was looking for. Table 4. So of these sessions, 1,100, how many people need NAS-native medications? So about 31% of sessions required them. And the vast majority was an anti-nausea medication. Like I mentioned, looks like lorazepam, it was 16 sessions. And while my recollection is I only administered it once, this includes people who self-dosed lorazepam from their own supply. Like if they received it from an outside prescriber, they already had a fill of lorazepam, they would take it sometimes as prophylaxis on their own. I wouldn't exactly call it against medical advice, but I recommended people abstain from benzodiazepines when possible. And that's actually an important point that to make note of is I tried to minimize the use of benzodiazepines because of some of the data out there that suggests they could minimize or reduce the benefits of ketamine. So perhaps some of the responses, the good response above 80% that we see in this study is a reflective of minimizing the use of benzodiazepines. It's not clear. Going back up, we're talking about the response rates. So you can see, yeah, started out pretty high and maintained after 3 months, after 6 months, and some degradation in those benefits by 12 months and 2 years. However, this is difficult to interpret because of the attrition rates. You see that we started with 55 individuals in the efficacy cohort, the individuals that were whose treatment plan was to do an induction. So by 1 year, you had only 21 individuals in the cohort that were still receiving ketamine at a year mark or onwards. So hard to interpret what it means if there's only 12 because of all the attrition. But we can say, with at least half of the cohort remaining in 6 months, with a response rate above 80%, it's pretty good. And if you look at it with intention to treat, meaning we consider it's probably the most conservative way of interpreting it. Everybody who dropped out, everybody who's not participating, we'd say they're not a responder. It's still above 40%. And I'll get into the dropouts a little bit later, We did an analysis for why people dropped out. And in truth, it doesn't seem like efficacy or side effects is the biggest thing. So it's actually a pretty good response rate. Let's look at figure 2. So attrition over time. You see the visits here and the x-axis. The induction, approximately 6, started at 55 and over 10 visits, 20, 30, 40. We're looking at days in treatment here. We're getting into a few years. So it does drop off over time. That's one of the limitations here, is by the several year mark, the data we're kind of, it's hard to conclude what that really means because there's so many people who moved on. The neat thing we can see though is the ketamine dose was relatively stable. It did go up a little bit over time. As I mentioned, it started around half, went up to about 0.9, and during the maintenance phase, it was around 1.1 was the mean. It did gradually creep up at points, but it didn't go anywhere crazy. I generally kept it below 1.5 milligrams per kilogram. That was sort of the hard cap that I use for folks, just because I'm a psychiatrist, I'm not an anesthesiologist. I don't have the ability to put an emergency airway in, so I decided to keep it to a relatively safe dose threshold. And it's of course arbitrary to say 1.5 milligrams per kilogram, but that's what I set it at. And interestingly, most people did not go to that high mark. Most people kept it a lot lower. My clinical impression was that people, once they got too high of a dose for them, they started feeling more sedated, longer recovery times, more nausea, and they didn't get better outcomes with depression. There does seem to be a good reason to go up past the 0.5 milligram per kilogram to maybe around 1.25, something around there. But do people really need to go to 1.5? Do people need to go higher? I certainly had a few individuals that did want to go up all the way and they did benefit. And there's also quite a few individuals who kept below 1 milligram per kilogram. I noticed Boris is here. He just popped up. I think he's just getting out of the OR. Maybe he's still in there, but he's my co-author. Feel free to say hello if you can. I don't know if you're muted, but oh, there he is.
Going? I'm gonna stay muted for the most part.
Yeah, sounds good. Sounds good. And yeah, I was just saying, Boris was the kind man who was able to figure out all the statistics on my behalf, since I wasn't sure which model to use. But yeah, so we saw that the CGI-S dropped quite a bit from the start, from the baseline through the induction, and maintained. There was some degradation that by the higher visits, by 40 visits after some time. Let's see. So let's go to the dropout analysis. This is the figure I was looking for here. So we have the people who were part of the induction. This includes the 55 that were included for the efficacy, plus those 4 who were excluded for the efficacy because they weren't sufficiently morbid according to the CGI-S. So that's why the 59 figure comes through. So, we have 50 people who completed the induction phase, another 50 who were in the maintenance phase. And why it goes from 50 to 50 is some people stopped after the induction, didn't continue, and other people were accepted directly into the maintenance phase. So this 11 over here is what comprises that, makes up that 70 that was for the overall tolerability analysis. So we see that of all the dropouts, of all the people that participated, there's 62 dropouts. Most of the time, it was logistics. That's why people didn't opt to continue. And logistics includes costs, it includes commuting, it includes not being able to drive afterwards, it includes just the sort of is it worth it? That sort of judgment call that patients were making. A few people were lost to follow-up. Not that many people actually said that it didn't provide a sufficient benefit, that it didn't work, so to speak. And not that many people either said that it had too many side effects, which is the interesting part. It seems like the biggest issue, according to what what we could find, is that it's just a pain in the ass to make it across town and not be able to drive and have all this time off of work. Well, probably that's compounded by my practice being open. I don't have like weekends, I don't have nights, so it makes it harder for people with full-time jobs who don't have the flexibility. Interestingly, some of the side effects that were maybe most notable or most scary, we had a couple suicides. Those are the serious adverse events. Those occurred, it was 71 days and 300 something days after the last ketamine sessions. So it's, in my mind, that's reasonable to conclude it's probably not due to the ketamine. And the other big serious adverse event was a person who, this fellow right here, developed new onset ketamine use disorder. So that this person went off the deep end, so to speak, in using ketamine and using other substances. And it was his first time receiving ketamine at this practice, although we had a history of polysubstance abuse and multiple substance use disorders, had been in residential treatment previously. So he was already had a pretty big substance use burden in the past. But of the side effects that happened, most of them tended to be pretty mild. We also notably didn't see much for urinary pathology. There is this concern when I started doing this work that ketamine is going to have a pretty high bladder toxicity, and it's unclear at what dose, at what frequency, what kind of model of use is going to provoke that. And we certainly see that in the abuse populations, people who are using ketamine recreationally, illicitly, on their own, using big doses, using it every day, using it a gram, and so forth. But I haven't seen that in this cohort of 70 individuals. And it may be because, as you saw, it's about every 3 weeks on average that people are receiving maintenance ketamine. And the other thing that's notable here is the ketamine is being administered as an IM, or in other clinics, maybe an IV infusion. Whereas if people are using it illicitly, recreationally, they're using it nasally, it's getting some first pass metabolism. People are using bigger doses to compensate for the lower bioavailability of using it nasally, of using other methods. So whatever the reasons are, it seems like in the abuse population with big doses, big frequency, that does happen. In this clinical population, it doesn't seem to happen. And maybe it just, 70 people isn't enough to detect those sort of low frequency events. But in my mind, that does point to the general safety of ketamine. The other thing is when we're considering the outcomes, the serious adverse events with suicides, with ketamine use disorder, it's important to remember this population, there's about 70 to 80% of people with suicidal ideations, whether it's passive or even active. So it's a pretty high amount. And this is also a population who has 50+% of substance use disorder comorbidities. So this is an addiction psychiatry population too. So does this extrapolate, does this generalize, so to speak, to use of ketamine in populations of folks who are just depressed? Well, it's certainly something we want to be on the lookout for. Anybody who's being treated for depression, we want to be vigilant for suicidal ideation, for worsening, for decompensation. And anybody with a substance use disorder in particular, or anybody who's naive to substances, who's getting ketamine, we probably do want to be really cautious and on the lookout for any of these things that pop up for people who are reporting like, well, I kind of like ketamine more than I thought I would. I don't know, I'm kind of thinking about it more. And in my clinical experience, it hasn't happened that much. Just this one individual was probably the most prominent example of that. I think, let's see, is there anything else I wanted to go through before we kind of open it up to the general discussion? No, let's talk.
Okay, that's great. Let's talk indeed. Thank you very much indeed, Wes. Lots of interesting things there. Do please either put your questions in the chat or stick a hand up, and we'll try to field all those questions. So, okay, Tiago Gill, first out of the pits here. How was the dose decided, and why did you when did you decide to increase the dose? How did you do that?
Right. So pretty much started everybody off at 0.5 milligram per kilogram. It was weight-based dosing. Initially, it was 0.5 milligram per kilogram, and after the first year or so, I started to be a little bit more flexible with that. Some people were started at a slightly higher dose if they had severe depression or suicidality, and they were wanting kind of, we talked about it, I talked about it with some individuals, if they really wanted to try something that could have a quicker response time, basically start at a slightly higher dose, then we could do that. And that was based on some findings by Lori Calabrese out of her private practice. I want to say that was in Connecticut or somewhere over there. She's had good luck doing that, starting people at 0.75 instead of 0.5. The dose increases were pretty much, it was modeled after working in OTP at the opiate treatment program. Since I'm an addiction psychiatrist, I had plenty of experience doing that in fellowship, but essentially in those programs where we give the patients the ability to say, hey, you want to go up the dose? Let us know. We can do that. You want to go down the dose? We can do that. So whatever works for you. And the idea with the dosing methadone is to have people feel satisfied with their opioid cravings. So it's a similar way with ketamine. Is sort of, I left it up to the patient for the most part to say, well, do you want to go up with a dose? Do you want to go down with a dose? Let's do it. And if, for example, they had really severe nausea or maybe they had emesis, I'd say, well, maybe we shouldn't go up with a dose, or maybe we should maybe back down. Or if they found like, well, I was like totally fine, I didn't have any issues, and I'm kind of curious to see what a higher dose is like. I'm kind of curious to look at the, have that psychedelic experience. I said, well, yeah, let's go up. So essentially, every subsequent visit, I offered a 10 milligram dose increase. So it was pretty much always on the table unless there was some pressing side effect. I recall there's a few occasions where people had such a long recovery time at a certain dose, longer than average, longer than most other individuals. I said, well, let's maybe not go up in the dose because you were still having some gait abnormalities. You weren't looking totally stable once the appointment ended. And actually, that's a good point that I didn't touch on in the presentation earlier, is that most of these visits were 1.5 hours long. Some of them were 2 hours long. So this is really pushing it on the amount of time we have to do this kind of work. It's certainly better to have 2 hours or longer just to allow the effects of the ketamine to dissipate. And this was, people were dosed with ketamine and essentially they were allowed to walk out after 1 hour from the intramuscular injection. So it's better to have a little more time because some people, they take a little longer to metabolize it. Some people, it lingers more, especially the higher doses. May I continue, Rupert, with the
question? Yes, you take them as you want, and I'll help.
Yeah, because Allison was asking if I split the dose, and that kind of is a good segue into what I was just talking about. I usually did not. There's a few individuals I've started to do that with subsequent to the completion of the data collection here in 2022, I believe, was the cutoff point. But especially in an 1.5 hour long session, there's not enough time really to split the dose. That was probably the biggest issue is in patients I see now for 2 hours or longer, there is time we can do split dosing, but I wanted to have people have at least 1 hour of recovery time from when they receive the IM. So most people, this is a bolus, and it was given by about a half hour into the hour and a half long appointment. So they had an hour before they were discharged. So let's see, next question. Did you include additional psychotherapy sessions, integration between IM sessions? It varied from patient to patient. I was trying to do this in a way that was most economical, that allowed the most access for people. And it wasn't a strict requirement to do integration sessions in between or additional sessions in between. Some people I certainly have seen in that capacity, but it's probably a minority of folks. And most people showed up in my practice seeking out this modality, ketamine-assisted psychotherapy. Most people were not established patients who I was seeing in other capacities and decided to. So there's all these nuances to it. And if there is a psychiatrist or a practitioner out there who has established rapport and a good relationship with a patient, that would go a long way towards facilitating CAP course. Let's see. Oh, and one thing I would add too is the preparation sessions at first, they were not mandatory as part of the clinical procedures, but I made it so after, let's say, in. So I want to say it's like 60-something% of people had a preparation session, at least one, and some had several, but that data is in the manuscript as well.
Can you say a bit more about what happened in those preparation sessions?
Sure. Yeah. I sort of glazed over the clinical procedures when I was speaking earlier, but maybe I'll give a little bit more. I'll speak more to that. Yeah, the preparation set. So people came in, I saw them for an hour for the evaluation, came up with a treatment plan, collected all their history and such. Then they had an hour-long preparation session, and then they had the 6 sessions that were typically 2 per week over about a month, usually 6, sometimes 8, sometimes 4 or 5. The preparation sessions were there to build rapport, to collect more history, to collect more background, to help people maybe create a focus for what they wanted to talk about, what they wanted to inquire in terms of the psychotherapy aspect. So how are you supposed to do psychotherapy with somebody when you don't really know them, right? That's sort of what this is getting at, is you have a period of time to build trust, to build rapport, to get people more familiar with the setting, to get people more familiar with the actual environment, the couch, the building, and it just makes people more comfortable. In addition to making people more comfortable, there'd be oftentimes goals or different life struggles that people had that they're trying to resolve. You know, like I can think of several patients of mine who had recent romantic relationships go sideways. So it was a lot of focus on, say, that, or, you know, the divorce or other kinds of issues, right? But the preparation sessions would try and zero in on what kind of conflicts are happening for people. I can think of one individual recently, which would maybe a good example, which would be illustrative of this, is that the person had, he's kind of an irritable fellow. He's very successful in his career, but he is very perfectionistic, right? So that initial preparation session sought to collect more detailed history, more examples of where things went awry with interpersonal interactions on the job, what kind of patterns came out from these interactions. And what it seemed to be after talking to him for a while is he's a perfectionist. He was very compulsive about, you know, dotting the I's, crossing the T's, judgmental about failures of other coworkers, and that, you know, so this perfectionistic tendency, for example, was one thing that we were able to zero in on and discuss and say, oh, okay, this is a good focus for what we want to talk about in the coming 6 sessions. So building rapport, getting more information, kind of coming up with ideas of what do we want to focus on in the ketamine sessions.
Just on this, were they self-referrals, or were you referred them by other people?
Most people found me on their own, but I think at some point because I was active on the various Google groups. People said, "Oh, Wes Ryan, he's in LA. That person, maybe you should see him." So it was a mix, but it was mostly self-referred. I got a few people from the Multidisciplinary Association for Psychedelic Studies, MAPS, had like a referral group, and I think Psychology Today and my website. So it's a mix.
Sorry, Wes, what we were talking about the preparation session, and you said that you introduced them at a certain point, right? Did you notice any change in terms of retention rate or ability to tolerate the infusion after you made it mandatory?
Oh, I see. Well, so one thing I would notice, or note, or rather point out, is that these were IM boluses rather than infusions. That's just a small point. Once I started making the preparatory sessions mandatory, I don't recall, I never made a connection between worse outcomes or worse retention. I think it certainly was something that an additional visit before starting the CAP sessions, but most people understood. I think it's sort of it's embedded in sort of pop culture with psychedelics that you want some preparation, integration, and processing. So people were kind of understanding and said, okay, yeah, I understand it's more time and more expense, but okay, let's do it. If you think it's the thing we should do, doc, then let's go for it.
Thank you.
Okay, Ramunas asks, why did you choose the CGIS? Any use of any other questionnaires, Madras, PHQ-9?
I use the CGIS because it was I could do that, and it was easy and it was fast. It was the fastest thing, and it's also transdiagnostic, meaning that it accounts for depression, it accounts for substance use pathology. It's sort of a global inventory of all their mental health and addiction issues. So it was just like the most convenient thing in clinical practice. I had toyed with doing the kids SR, the kids self-report, and I toyed with doing like the Madras, but it was just it ended up being quicker for me to do the CGIS, and that's why I ended up following that.
And you did it at the same time rather than retrospectively?
Partly, part and part. So sometimes I did it retrospectively, sometimes in the moment. Yeah. And
Okay.
and actually the reason, one of the other reasons to use the CGIS is because there is good data about how it compares with the Madras, right? It is a validated instrument, and it has a long track record of use. So it has a lot of data behind it to say that it's valid, and it's a useful measure of people's mental health and their response and so forth.
Yeah, and Henry McConnell's making the same point. Yeah, he supports that. Just a question from Tiago. Were patients kept on their oral medication?
Yeah, and so one of I didn't get into it in great detail, but I was also managing people's medications outside of doing the ketamine injections and doing the psychotherapy. So some people were started on new medications, some people, their medications were continued, some people discontinued medications. One thing that when Boris and I were looking at the data early on, we had this question of like, well, when people are getting ketamine, are they just suddenly stopping their SSRIs because they're so much better? Because that would be a really cool finding. And we didn't actually see that. It seemed like in my clinical experience too, is that people would get gains from ketamine-assisted psychotherapy. They'd see improvements in their depression and so forth. But they would also get more gains with an additional, say, SSRI, for example, if they were taking daily. And most people thought like, well, let's add in this other stuff. So it was, I guess I would say it was maybe uncommon that people felt 100% after just the ketamine. Oftentimes it was the ketamine and the psychotherapy. Oftentimes it was other medications that were added into the mix as well.
Steve asks, do you have any information on what happened to the level of benefit of the dropouts? So in other words, what happens after stopping the ketamine?
What happens after stopping the ketamine? Well, a lot of these people, we just assessed them when they came back. So some people stopped coming in, of course, or they were just lost to follow up, and we don't know. Hard to say.
Okay. Did you try to track substance abuse in your Eþēภิc cohort, since about half report SUD?
Sorry, what was that? Did I track?
Did you track substance abuse, or was that part of the CGI?
Yes. Yeah. The CGI-S it included their substance use psychopathology as well, and I was pretty careful to assess for that in each visit. And I mean, I'm an addiction psychiatrist. That's a big part of my patient population. It's something that I'm attuned to just in my general practice as well because of that training. So yeah, that CGI-S does include sort of, for example, one fellow was, I don't know, drinking 12 White Claws a day. Do you all know what White Claws are? It's sort of like a non-beer alcoholic beverage that comes in a can. So this person was drinking like 12 of those a day, right? And that was sort of at their baseline or more. A lot of drinks per week, 12 standard drinks per day, sometimes more. And over time, that would, he's now, after, I want to say it's like 8 years in treatment, because he's still with me now. He's down to drinking like, I don't know, three drinks per week. So that would be, one reflection of how well he's doing. That would be included in the CGI-S. 12 drinks a day and losing control with that, waking up, vomiting, all this kind of stuff, and now sort of barely not drinking only in moderation.
Thanks. Henry asks, do you have data on the percentage of individuals who were or weren't receiving concomitant psychotherapy? I noticed you had 91% had a history of having had psychotherapy, but what about current psychotherapy?
Right. Actually, that's a really good point. So, of course, I was providing the psychotherapy during those sessions with people. That was a big component of every visit. But that is a really good point, that a lot of people had their own psychotherapists as well, but they had longitudinal relationships with, that they were seeing before, during, as well as after the ketamine sessions. So that's a good point. I did not collect that kind of data, but my impression is that 40–50% of people probably had, maybe 30 to 50% of people had an outside psychotherapist that they had an existing relationship with, and some level of regular interaction, be that sometimes once a weekly or monthly, something in that range.
Henry, do you want to comment on that?
Yeah, thank you for that, Rupert. Yeah, and thanks, Dr. Ryan. It's on my mind because in an analysis that I published this fall in Journal of Psychopharmacology, we similarly had a breakdown. I think it was 60% with the psychotherapist concomitantly, 40% without, and we found a medium effect size, 0.51, favoring the PCL response in those who had the concomitant psychotherapy. And then in an unpublished post hoc that I conducted, found a very substantial difference in response rates. So 59% response rates in the group who did not have a psychotherapist concurrently during their infusion series, 6 infusions, 82% response rate in those who did. So something,
wow.
Yeah, big jump. And so I have some unpublished data looking at PHQ, GAD, and PCL, and by far the biggest margin was in that PCL measure, and so I'm looking to potentially publish that. But it's correlation, it's association. We don't know what it means. Does that mean people were better resourced? But in a lot of covariate analysis in that study, that was actually the only significant covariate that I could find, whether or not someone had a concomitant psychotherapist outside of the treatment.
That's really fascinating. It makes a lot of sense, right? With this way that we conceptualize how psychedelics work and how they facilitate psychotherapy, that having those, that opportunity for those interactions, for self-reflection with a person who's trained in psychotherapy, can be super duper useful. So it makes sense to me too. And like you said, hopefully, maybe it's just correlation, but I suspect it's more than that.
You had another question, Henry.
Sorry,
If you don't mind me,
Sorry to jump in the conversation, but Henry, I was under the impression that your study was mainly on PTSD population.
yes. Yeah, so it was a comorbid population. So it was the primary PTSD, but similarly to Wes's study, we had about 70% of the individuals with comorbid anxiety, depression. Yeah, it was a pretty significant range of comorbidity in the study. Yeah.
Thank you. Sorry,
Yeah,
didn't mean to interrupt.
Thanks for
Please.
jumping in. Glad you had seen it. Happy to put the link in the chat. But if I could jump onto the other point, I mean, I just want to give a giant shout out to Wes and Boris, because this is a very, very diligent collection of safety data, way beyond what I was able to find when I did my analysis of the clinic I worked with. And I think really speaks to the fact this is a primary clinician-led study. And I'm so curious just to hear more about the process of being so granular and diligent, and how you arrived at the variables you did collect. I think it could be easy for many CAP clinicians to wave their hands and say, oh, well, this is sort of just the CAP experience, but you got very granular, and just was curious to hear what that process was like. Yeah.
Yeah, definitely. I mean, I don't think I would have settled on being so attentive to all these different factors were it not for doing some literature review on ketamine prior to starting my practice. So I was already very interested in the use of ketamine for mental health indications, and the data was best for depression and somewhat for PTSD. But so at first I was very much like straight and narrow. We're only treating depression in here, and if you have comorbid substance issues, then totally you still qualify. But yeah, I don't know that I would have been as attuned to, say, the urinary pathology possibilities with ketamine, with long use of it, high doses in the substance abuse population, and all this idea that maybe chronic use of ketamine can cause some cognitive disruption. So I sort of had this stuff on my mind already when I started the practice, and I was very cautious to assess for that stuff in particular at essentially every visit. Some of the other variables, say the diplopia, for example, I wasn't asking the stuff at each visit. It was maybe some of this stuff was if it was spontaneously reported by the patient. But yeah, I had already a pretty good read on the literature as it was being put out at that time. So I was kind of thinking, like, how can I answer these questions for myself in my practice and make sure I'm doing it in this really good way. And like you were saying, that it really helped that I was the only one essentially doing the only psychiatrist doing the ketamine work in my clinic, and doing essentially all the psychotherapy myself too. If it had been multiple providers, it probably would have been unrealistic to get this kind of consistency with the data. I'm a little bit I'm a little compulsive on my own too, so that probably helped those. Made sure to check all the boxes and made sure to ask all these questions at every single visit too. I had a pretty extensive sort of internal thought process of what I wanted to ask for every psychiatric evaluation. So all those questions were pretty much collected at every visit. And yeah, I know that a lot of community clinics, a lot of other clinics, maybe they don't ask all this level of detail. So that was maybe one of the strong suits here too.
Thank you. How do you decide to stop using ketamine, to stop the treatment?
Well, most people find that if they stop, they have some level of decompensation. Some individuals, of course, have had great outcomes. Maybe they receive one ketamine session or an induction. They're doing great for 6+ months. But essentially, my model approaching this was that people probably needed some level of ketamine in perpetuity. And at first, I usually suggest that, okay, let's, you finish the induction, let's maybe meet in a month, in 3 weeks, in 5 weeks, something in that neighborhood. And we can adjust upwards or downwards in frequency. And over time, people maybe, oh, they're doing well, monthly. So we space it out to 6 weeks, 2 months. And invariably, some people would say, I'm feeling good enough, and I'm just going to pause the ketamine treatments. Sometimes I wouldn't hear from them, or I'd continue to see them just in a capacity to manage their medications. Or in other cases, they'd say, hey, yeah, that actually was helping quite a bit. I feel like I've decompensated. We'd restart, we'd resume.
Can I ask about the painful issue of the 2 suicides? You did talk a little bit about that. And obviously that's a risk of this sort of work, as you said, with the population. Was there anything that you found that you sort of wondered about in retrospect with respect to the interval between the doses? Was there any warning of this? Was it somebody who'd relapsed and had not had the finances to come back early enough, or what were the sorts of? Can you say anything about that?
Yeah, I mean, these 2 unfortunate outcomes, these individuals essentially, I think they kind of gave up on treatment and stopped coming in. I hadn't seen them for quite a while, and only learned quite a bit later, I believe in both cases, both those suicides, that they had died. So it was not, they weren't actively in treatment really when this happened. I think they sort of dropped off, and maybe it didn't work as well as they had hoped for. I can recall one of the 2 individuals who killed themselves. He was a guy in his early 20s, and long history of mental health issues in his childhood, and sort of difficulties establishing in school and in a career path. So yeah, those people were doing worse in terms of their mental health, in terms of their CGIS scores were pretty high, and in terms of pre-existing suicidality. That one individual, I recall working with him, and it was constant that he would have pretty severe suicidal thoughts. This was not something new. It's not something that started after ketamine. It was a big part of why he was seeking ketamine is because he was refractory to all these other treatments he had tried thus far.
Were they particularly invested in the idea that ketamine was their sort of last and final hope, or not?
The other person I do recall that kind of that's what came up was I believe she was thinking like, well, I've tried everything else. Let's see how ketamine works. And it was maybe a bit of a letdown that like, this thing that's supposed to work in treatment-resistant depression did not work for me. So this level of disappointment, or right, that like, I thought this is gonna kind of bail me out from this depression. So there's that kind of psychological factor at play, probably played a role. Demoralization, if we can call it that.
Okay. Do you have any sort of tips for those of us that are using intravenous ketamine, about using it intramuscularly? Do you think, for example, that the higher peak concentration means that this has a greater efficacy, do you think, or have you not been using it with IV, so you can't say? I mean, do you have a sense of this?
Yeah. I mean, it's not something I really dabbled with too much, the use of ketamine as an IV infusion. I've pretty much always given it as an IM, and almost exclusively as a bolus early on. And more recently, in some patients, I've been splitting the dose. My impression is it lasts from an IM bolus versus a 40-minute infusion. It lasts approximately the same time, where people are in that ketamine space, where the psychoactive effects, the drug effects, are pretty profound. And of course, like you were getting at, Rupert, the peak drug effects and the peak intensity of experience is higher with the IM. There's a peak early on, it sort of fades. And that quality of the IM versus an IV infusion is certainly quite a bit different. It can be more of a roller coaster ride. I don't know if it's actually a better thing for the IM. It's certainly easier and less logistically complicated to give an IM, whether it's a bolus or split dosing. But one thing I've heard from patients, just sort of anecdotally, is that sudden onset of drug effects with an IM bolus can be a little disconcerting. It can be almost a little bit like, oof, well, okay, we're on the plane's taking off. And it's a rocket ship going to Mars, right? Rather than a smooth liftoff. And actually, in a patient I've been working with recently, we've come to figure out that splitting the dose and doing maybe a third of the total dose at first, and then 2/3 of the total dose after about 15 to 20 minutes provides a lot smoother takeoff, if you will. And I suspect this isn't a factor in IV infusions because there is that initial takeoff, but then it's relatively flat, the drug levels and intensity of experience. But in the data, the people seem to do pretty well with an IM bolus or an IV infusion, and doesn't seem to be huge differences. That's kind of what I take away from this data set and from hearing other clinicians and patients' experiences.
Just out of interest, were you actually administering these IMs yourself, or do you have a nurse in clinic who's doing it?
It's pretty much just me. Yeah, I don't have any staff at this point. It's just me showing up to the office. I think some patients are also pretty like, oh wait, Dr. Ryan Associates is actually Dr. Ryan. Yeah, so it's mostly a solo operation.
Wow, well, that's quite an achievement then for a solo operation, isn't it? Amazing to have pulled all that together, and thank you very much indeed for taking the time to sort of go over it in such detail. Thank you. It's been really interesting, and
it's my pleasure to share, and thank you so much for the invitation.
We've really enjoyed it. Sarah, can you tell us what we've got next?
Yes. So we will see again in January. So happy holiday, everyone. Let me just double check the date. I believe it's going to be the 13th of January, and we'll have Sam Wilkinson talking about his very recent paper on use of ketamine for bipolar disorder.
Fantastic. Thank you, everybody. Thank you, Wes. Thanks for all your contributions. Great to see you all, and see you again next year. Happy Christmas and all.
Hopefully I'll make it out to Oxford for the next conference.
That, of course, would be wonderful.
Great.
We really look forward to that.